Good afternoon, everyone. My name is Joan Gatorf. I'm a professor in the School of Nursing at UBC Okanagan campus, and I'm also director of the Institute for Healthy Living and Chronic Disease Prevention here at our campus. So I'm really delighted to welcome you all this afternoon. Before we begin, I want to acknowledge that UBC Okanagan is situated on the traditional, ancestral, and unceded territory of the Silk Okanagan Nation. I also want to acknowledge that you may be joining us from other places, both near and far, and I hope you take a moment to acknowledge the traditional owners and caretakers of those lands as well. I must say it's a beautiful day in the Okanagan today. I'm overlooking the lake and it's like glass. So it's really lovely. I'm delighted to be able to live and work here in the Silk Okanagan Nation territory. So I want to welcome you to the 10th annual Okanagan Embrace Aging Month. And again, thank you all for joining us today. Embrace Aging is co-hosted by the Institute for Healthy Living and Chronic Disease Prevention, but also by our partners, Interior Savings and Credit Union and Interior Health. UBC Okanagan has also joined the global network of age-friendly universities, formalizing its pledge to make UBC more accessible, intergenerational, and committed to research programs that are informed by the needs of an aging society. If you want to know more about the Age-Friendly University Initiative or have suggestions for us or want to get involved, just contact the Aging in Place Research Cluster. And you can reach them by email, aging.inplace, all one word, at ubc.ca. So Embrace Aging was launched 10 years ago to celebrate and raise awareness about positive aging. And once again, like every other past year, we've organized a number of educational opportunities and events during the month of March. And many of you may have had an opportunity to join some of our previous events. As you know, our sessions are designed for everyone, young and old, and focus on a variety of topics related to healthy aging and ways to improve quality of life. Our goal is really to inspire each and every one of us to embrace positive aging. So just a couple of housekeeping things before we begin. There is a closed captioning box that may appear on your screen. You can move it around and you can close it off by selecting Hide Caption button on the menu bar. There will be an opportunity for questions and discussion towards the end, but at any time during the session, you're welcome to type in comments or questions into the chat box, and we'll read those out towards the end of the presentation. So today's event is one of many that we're offering through the Embrace Aging Month. And the title is Adapting to a New Knee, What Matters to Patients Undergoing Total Knee Replacement. We just had a little brief discussion before the session began, how everyone knows somebody who's having trouble with their knees or maybe has actually had a knee replacement. So I think this will be of great interest to all of us. So I'm delighted to welcome Randall, who is a PhD candidate in the School of Population and Public Health here at UBC, University of British Columbia, and Dr. Charlyn Black, who is also in the School of Population and Public Health at the University of British Columbia on the Vancouver campus. So welcome, Ellen, Charlyn, I'll turn it over to you.
Thank you.
Okay, thank you very much, Joan. For everybody, I'm Ellen, and I'm here with my co-author, Charlyn, and we're here today to talk about the study we undertook with people who've had a total knee replacement, a study that allowed us to learn from those patients what they felt was important when they were thinking about whether this procedure was successful for them. And although we didn't do a poll specifically for this presentation, we decided that it might be good to start out by asking those of you who have joined us whether any of you have already had a total knee replacement And given that there isn't a poll, if people could just answer yes or no in the chat, that would be great.
And I think there's been a question put into the chat just for your information, so we can.
Oh, okay. That question or a different one? Because I'm not.
So I noticed that someone says, just got a new a week ago, feeling really good and walking. Great news. And then how many other participants have had a knee replacement? No, but considering. And then my guess is we have a lot of other people who have creaky knees like I do.
So hopefully, whether you've had a replacement, you're contemplating a replacement, or your knees are just creaking a little bit, there will be something for everybody in this presentation. So I'm going to interject one note of housekeeping, kind of like Joan mentioned at the outset. I'm working and presenting today from my home office, which is in a somewhat noisy neighborhood, as I'm situated on the corridor that the ambulances use to go to St. Paul's Hospital. I'm very much hoping that no ambulances will be going by during the presentation, not only for our sakes, but for the sakes of the people who might otherwise be ending up in those ambulances. If that happens, I'll simply pause until they've passed so that the noise doesn't override the presentation. So, hang on a second. So I wanted to start, first of all, with a couple of acknowledgements. This study is part of a larger research project, which is called the Patient Experience with Arthroplasty of the Knee, or much more manageably, the PEAK study. And the PEAK research project includes roughly 500 patients across the province of British Columbia. I also wanted to acknowledge our two co-authors, Dr. Sterling Bryan and Dr. Laurie Goldsmith, who are not here with us today. So just a little snapshot of what I'm hoping to share with you through this presentation. I'm going to start with a very brief overview about what is a total knee replacement. You'll note that I've put TKR in brackets. Total knee replacement's a bit of a mouthful, so I may at times refer to it as TKR. And if I do, I'm simply referring to a replacement. I'm then going to do a bit of a deeper dive into the idea of patient satisfaction with total knee replacement, and then share the findings from our studies that relate to how people think about satisfaction with this procedure. And then in closing, I'm going to suggest a couple of ways that our study revealed we could improve rates of patient satisfaction. And then at the end of my presentation, I'll be turning over to Charlyn. So starting first with total knee replacement. This is a surgical procedure, and it's the most requested and performed procedure, joint replacement procedure, I should say, in Canada. Despite all the challenges and chaos thrown up by the start of the COVID pandemic, in the fiscal year 2019 to 2020, we still managed to do 75,000 of these procedures across Canada. And the volume of this procedure is very much on the rise. And in part, that's because people are increasingly having this surgery done at a younger age. Conventional wisdom used to be push your knee replacement as far out as possible, because the later you had it, the better the chance was that you would never have to have your replacement replaced. Over the last decade or so, and I think in part because of the baby boomers entering their senior years and being very focused on good quality of life, the philosophy has changed, and more often people are having this surgery done at a younger age, so that rather than enduring pain and other symptoms through their 50s and 60s and 70s, they're instead getting the surgery done and being able to resume activities and improve their quality of life. And in part, this trend has been supported by the fact that the newer implants that are being used have a longer lifespan than the older implants. So why do people have TKR? The most common reason to have a knee replacement is to address symptoms of osteoarthritis, or OA. And osteoarthritis is a progressive condition, is associated with aging, and it's a leading cause of disability worldwide. And interestingly and appropriately for our conversation today, one of the most common sites where OA manifests is in the knee. So typically what happens is silent changes start to occur within the knee that eventually become noisy enough so that a person begins to register the onset of symptoms. And eventually those symptoms become intrusive enough that they elect to seek care. And seeking care may include having a surgical consult and ultimately a decision to have surgery. And that surgery is then followed by a recovery period, which they say can range from 3 months to 12 months, all things being equal. But it's important to note that the decision to have surgery involves either directly or indirectly expectations on the part of the patient that this surgery is going to give them some degree of alleviation of symptoms and or improvement in their activities. So the TKR promise, from a patient perspective, the TKR promise is pretty compelling. This is a promotional blurb that I took from an orthopedic surgeon's website. And you can see that it promises benefits that are pretty significant and meaningful and pretty far-ranging. It also positions this procedure as one that is both routine and successful. And in reality, for most patients, TKR is a successful procedure. However, studies have found that as high as 15 to 20% of patients say they are not satisfied following a knee replacement. And this rate has been pretty persistent over time, despite ongoing efforts to improve it. And given the hopes that people going into this surgery have and the not inconsequential recovery period associated with it, and given the high number of TKRs being done annually, it's clear that we need to continue to work to improve the satisfaction rate with this procedure. Otherwise, if you think about the 15 to 20% and take the more conservative 15% and cast your mind back to the 75,000 surgeries done per year, this would translate into roughly 11,000 Canadians every year having a very significant surgery and not feeling that they realize the benefits of the TKA promise. So studies looking at TKR satisfaction have largely tended to measure it by asking patients to answer questions rating their satisfaction. And this is an example of just such a question. And these surveys also tend to ask questions about factors that researchers anticipate could influence satisfaction, like what is your current level of pain in your knee? And while the answers to these questions have provided us with really critical intelligence relating to TKR patient satisfaction, we still have too many people who report not being satisfied following the surgery. And we haven't yet been able to sort of track that last 15 to 20%. So when we were thinking about our study, we wondered if part of the challenge might be that a survey question asking people about satisfaction doesn't tell us what satisfaction actually means to a patient. What do they mean when they're ticking off their choice in response to that question, whether it be that they're satisfied or dissatisfied? So our study set out to find out from patients who've had total knee replacements, what matters to them when they're thinking about satisfaction, in the hopes that if we could understand what they're thinking about when they talk about being satisfied or not satisfied, this knowledge would in turn help the healthcare system to find better ways to meet the needs of patients having knee replacements. And this is an idea that I think was very nicely summed up in this quote from Brian Williams, who basically says, if we're going to make relevant changes to help patients, we need to know what the heck they mean when they say they're satisfied or not satisfied. So for our study, it was a qualitative interview study that was designed to learn directly from patients what they mean when they're talking about satisfaction. We recruited 27 patients from across BC, and these were all members of that peak study cohort that I mentioned to you at the outset. Our participants were all 3 years post-surgery, so we could get a sense of how people felt about their knee after having a few years actually living with it. And in particular, we worked to include a good number of patients who had ticked off either dissatisfied or very dissatisfied in response to their survey question about satisfaction. So we could focus in on that group of people to get a better sense of what influenced that kind of response. So I then traveled, once we had recruited everyone, I then traveled around the province. I interviewed most people in their homes. A couple of people I interviewed at their doctor's office. And I basically asked them how satisfied they were with their knees and what things influenced their sense of satisfaction. So this is just a little snapshot of the people who participated. We had participants from every health region in the province, which was great for not only the study, but for me, because I got to see parts of the province I hadn't before. Our participants were more often female than male. Most of them were married. They covered a wide range of household incomes, and the vast majority of them were from urban settings, but I did have the privilege of traveling to some rural communities and hearing stories from rural participants about their experience with total knee replacement. So what did we learn? Over the next few slides, I'm going to focus in on the findings from our study. And I'm going to start with what came as a surprise to me. I set out to interview these people thinking that I was going to explore the concept of patient satisfaction with them. And in fact, it turned out to be a concept that they didn't actually readily engage with. Rather, through the course of their stories, they introduced me to two new ideas, the first being the idea of adequacy, and the second being the idea of adapting. So first to the concept of adequacy, I started each interview asking a participant how satisfied they were with their new knee at the time of our interview. And what I found was most people did not respond in kind. What they did instead was launch into a very detailed description talking about the perceived adequacy of their new knee. And while their stories inevitably varied in their details, the idea of a new knee's adequacy was common to all the stories, and it basically boiled down to the extent to which each person thought their new knee felt and worked the way they hoped it would, whether it met their expectations and whether it let them do the things they wanted to do. And so it was a big takeaway for me that talking about their knees in these terms was clearly more meaningful to the reality of their lived experience with these new knees and recovering from the surgery than trying to assign a level of satisfaction. So the next concept is the one of adapting. Participants also very clearly detailed a process, the process of adapting to their new knee following surgery. And what emerged was that adapting is how each person within the context of their life managed to physically integrate their new knee into their body and their life through the activities of recovery and rehab, and also how they came to cognitively accept their new knee and the extent to which it turned out to meet their expectations about how this new knee was going to feel and work. So it was clear across people's stories that adapting was straightforward for some of them and not straightforward for others, and that ease of adapting really mattered to them. Participants described adapting as straightforward when they did not have to make any extra effort to recover, when their symptoms abated as they expected they would, and the system support they received was perceived as sufficient. For others, adapting was described as not straightforward. They talked about symptoms that did not resolve easily or took a long time, recovery being delayed, and mostly they talked about the extra effort, somewhat considerable, that was required on the patient's part to both seek out and then undertake extra care. These people often described having to return to their surgeon and or repeated appointments with their family physician, finding ways to take more therapy, all of which meant that the knee, the new knee, remained a focal point and a cause for concern much longer than they'd expected that it would. It also became clear through our analysis that participants' assessments of adequacy and the straightforwardness of adapting were aligned. In a nutshell, higher assessments of adequacy went hand in hand with descriptions of more straightforward adapting. So keeping this in mind, we identified 4 levels of adequacy across our patient's story, starting at the top with optimal adequacy and then diminishing in adequacy through to the bottom category of insufficient. And I'm going to walk you through these levels over the next few slides, starting with the level of optimal adequacy. The stories we heard from people in this group position these participants as the poster people for a successful TKR. Adapting was entirely straightforward for them. Their symptoms resolved fully. Their expectations were met, as is evident in this quote that I've shared with you from somebody in this particular category. These people expressed no complaints, really, about anything. They've described experiences that were easy and seamless and pretty much how they'd understood recovery from this surgery would be and how their new knee in turn would also be. The next category is that of good adequacy. So the stories from people in this category were slightly less perfect. Many people had to work a bit harder at recovery and accept less than perfect symptom resolution. They described, for example, having to improvise with some of their activities. There was one person in this group who was an avid recreational biker and had gone into this surgery because they were very much hoping to get their full range of motion back. When they discovered after the surgery that while there was improvement to their range of motion, they did not get their full range of motion back. Rather than surrender that activity, they instead worked with a bike shop to make custom modifications to their bike to allow them to continue with this favorite pastime. So overall, the people in this group, despite identifying some compromises, were still really glad that they'd had the surgery done and accepted their outcomes, as I think is reflected in the couple of quotes that I've shared here with you. Moving to the next level, this is tolerable adequacy. And the stories from the people in this group were a bit harder to hear. They included tales of considerable extra effort at rehab because of ongoing symptoms that simply weren't resolving the way they'd hoped. And in many cases, they actually described having to forego desired activities. And these were not just recreational activities. People described feeling compromised, for example, in their homes because key activities of daily living, like housework, or being able to reach pots and pans in the lower cabinets in their kitchen, were all problematic for them and sometimes necessitated involving family members or even hiring people to assist them in doing daily activities of life that they had hoped they were going to be able to do on their own. And there were people in this group that started to express a level of frustration at what they felt to be inadequacy on the part of the healthcare system. They felt that the system was not helping them get where they wanted to be, resolving these symptoms. And they also talked about the concerns they had with the costs and inconvenience of having to seek out and then undertake additional care. Most of the people in this category had stopped trying to gain further improvement. And while they did say they accepted their new knee, it was clear that this acceptance was tinged with a palpable level of disappointment and a sense that their expectations had not been fully met. And again, I think that the couple of quotes here speak to that disappointment. So the final category is insufficient adequacy, and the group of participants in this category comprised those who remained actively and very unhappily focused on their knees. Their symptoms were either unresolved or in some cases were even worse than they had been pre-surgery. As a consequence of this, these people's lives were highly restricted at the time that I interviewed them. And some of them actually expressed regret at having even undergone the surgery. All of them, and I think because their symptoms were so uncomfortable for them, all of them without exception were still working to improve their outcomes. They were doing so both within and beyond the healthcare system. Their efforts included things like seeking alternative therapies, going to specialist pain management clinics, using medical marijuana, but mostly they were repeatedly trying to re-engage with the healthcare system, either with their surgeon or their family physician or both, in their quest to find greater relief. And as this quote from one of the people in this group indicates, these people were not willing to accept their knee. Their expectations were not met, and they did not feel prepared to settle with the knee that they had ended up with. So during analysis, it became evident that across the 4 levels of adequacy, as one moves down from that top level of optimal adequacy to the bottom level of insufficient, that there were 3 trends at play. The first trend was that as perceived adequacy dropped, unresolved symptoms became a bigger part of people's stories, as did the extra effort they had to undertake to try and seek extra care and therapy to get better results. The second trend was that, again, as you moved down that set of adequacy categories, expectations were discussed in greater depth. Participants were more likely to talk about either settling for a knee that did not meet their expectations, or for that last group, talking about, battling the healthcare system to get the results they'd expected, which never seemed to materialize. And that leads neatly into the third trend, and that was that as you move down the categories of adequacy, the perception of care from the system moved from being seen as sufficient to being viewed as insufficient. And in the extreme, the system was described as inaccessible and unforthcoming. So what does all this mean for patient satisfaction? So this study allowed us a glimpse into how a knee replacement is experienced by patients in the context of their day-to-day lives. And when there was a good and easy fit between what people had hoped for and how their new knee now felt and worked, people thought their new knee was adequate. When people's expectations for the recovery process and for how their new knee would feel and work were not met, people described levels of adequacy that were less than optimal. And while these people did not tend to use the language of satisfaction, these concepts and these findings still present opportunities to patients and providers to potentially improve rates of patient satisfaction with TKR. And I think part of that has got to be that in addition to the current primary emphasis on improving, endlessly trying to find ways to improve clinical outcomes to boost patient satisfaction, that in addition to those efforts, our findings indicate that we also need to look more closely at aspects of the patient experience with total knee replacement and see where we can make improvements there as well. So one such opportunity is the idea of shaping realistic expectations. So patients who are contemplating a TKR need to be as clear as they can be, first and foremost with themselves, and then with their providers, about what it is they're hoping this surgery can do for them. If they're longing to lace up their skates again and get back out on the rink, or kneel on their gardening pads and work in their garden, or resume running marathons, whatever their aspirations, these should be shared with their provider team. And providers, for their part, need to proactively work with patients to help them form realistic expectations about what this surgery can do. And these expectations need to factor in both what a patient is hoping for, as well as the reality of their situation, including things like their age and their mental health and their physical comorbidities and so on, things that could have an impact on what the surgery might be able to do for them. And this discussion needs to be just that. It needs to be in person as part of the pre-surgical consultation process. Studies have found that leaving patients to form appropriate expectations about what knee replacement can do for them on their own, based on the educational materials, which tend to be very fulsome, and most programs provide patients with them in advance of the surgery. But despite how thorough those educational materials are, studies have found that patients still walk away from that educational exposure forming unrealistic expectations. So I think the key is to have a patient and a surgeon talking to each other about what's reasonable. And interestingly, in our study, we found that there was a set of patients who did describe having a conversation with their surgeons, but it tended to be pretty much one-sided. Their surgeons told them that this surgery could fully resolve their symptoms. And in fact, for some of those patients, it did, but for others, it did not. Another set of our participants reported that they had absolutely no discussion whatsoever with their providers about expectations. They didn't share what they were hoping for, and they didn't get a sense from their surgeon what they should be hoping for. And I think those are both examples of lost opportunities. So the other opportunity I wanted to suggest, based on our findings, is that the healthcare system expand its capacity to provide ongoing support beyond the standard 1-year window for patients whose recovery may prove to be protracted. Even for some of the people who were in the good adequacy category, people whose symptoms were largely resolved, there were some people in that group who still had a desire to seek out more help to see if they could further improve their outcomes a little, even at the 3-year mark. So for their part, I think patients need to understand when they're going into this surgery what's available to them in terms of post-surgical support, and be prepared to advocate for themselves for more help if needed. A couple of our participants reported that they initially gave up when their symptoms did not resolve quite as they thought they were going to, because they'd run out of their covered physio appointments and they didn't think they could get more help. Eventually, the good news is that both of them, with assistance from their family physicians, did manage to access further therapy and were able to further improve their outcomes. So providers, of course, play a big role in this, and providers in the healthcare system need to find ways to increase capacity so they can provide broader patient support for patients whose recovery needs may not be typical. And there are already budding innovations to this end, such as the increasing use of orthopedic nurse navigator programs to support patients as long as needed following surgery. So these programs work that patients get connected with a nurse navigator who can help them decide if and when they should be referred back to the surgeon, can help them find community resources to support them, and can advocate for them if further therapy is needed. In addition to programs like that, there's also an opportunity to revisit what kind of rehabilitative support is provided to patients as part of our standard covered package. I believe the standard for physio is still 12 sessions. I know that that might range from one health region to another. But there's an example of where latitude could be given for further appointments for people who need more time and more help to achieve the best outcomes with their knee. So in closing, the ideas, these concepts of adequacy and adapting influenced how contented our participants were with their new knees. And these concepts point to opportunities for system change that are within our reach. Part of the challenge always is when you're thinking about how can the system do more, is you have to think about how complicated it will be to implement change, what's the cost associated with it. But these are fairly low-hanging fruit. Working with patients to set manageable expectations can be done within the context of a pre-surgical consult that's happening anyway. And modifying the care model to provide ongoing support as needed is still an actionable refinement. Creating an allowance with some criteria attached to it to allow some patients to have more physio appointments is not something that is going to require new systems to manage or frankly break the bank. But the first step to realizing these changes, I think, is for healthcare providers and system and program administrators in these surgical programs to develop to heighten awareness of how their patients experience adapting to their new knees in the context of their day-to-day lives. And with that, I am going to wrap up. Before I do so, I want to thank Joan for giving us this opportunity to present, and Jaquetta for all the support she's provided. I also want to acknowledge our study participants who gave very generously of their time and shared their stories very frankly. It was very moving. And of course, to acknowledge our funding agency, which is CIHR. So with that, I am now going to turn this over to Charlyn. I will keep sharing the screen with that slide up.
Sure. Thanks very much. I just want to say, comment on the remarkable work that Ellen has done as part of her PhD. This is one of 3 components of her PhD thesis. And I just feel like I've had the enormous privilege of serving as an advisor on her committee. And I just want to draw attention to how important this research is on focusing on patient experiences to learn about how to improve healthcare. Much of our research in this area relies on the ideas that we have as researchers, providers, and administrators. And this ability to actually talk to patients and understand how things worked out is so critical to help us improve care as we move forward. So this is, I think, deep qualitative research, and Ellen will be putting this research together with the quantitative to look at how do the standard responses from satisfaction line up with this deeper understanding that she's provided. So I just want to say thanks, Ellen. This is amazing work you've done and very relevant to patients and providers. Over to you, Joan.
Yes, I couldn't agree more. A brilliant study and very well done. It is interesting, I think. Oh, but before I maybe make any further comments, I'll just encourage people to put any thoughts or questions or comments that they might have in the chat box. We'd be delighted to hear from you. And any questions that you might have, we'll pose them to Ellen and Charlyn. So please go ahead and do that. In the meantime, yes, I agree, this is an excellent study. And it is interesting to think about, in the absence of conversations that might be happening with healthcare providers. I think many people just have conversations with friends and neighbors and other people they know who've had knee surgery about what their experience has been. So I think it's really important to encourage these conversations with healthcare providers, because otherwise we're left with just our own social networks to figure out what we might expect from from knee surgery. And even though others might have had great experiences, it doesn't mean to say we might not too. But I do think it's interesting to hear about such a wide range of experiences. And I'm wondering, Ellen, if you had any inklings about why we might see these quite distinct differences in experiences between people who have knee surgery, from, great adequacy and great adaptation to not so good.
I'm going to preface any response I make with the statement that I'm not a clinician. And so I think part of the answer is going to lie with, why did somebody's pain not resolve? Or why did, somebody's range of motion not come back the way they expected it might? I think for me, so there's two parts to my answer, Joan. I think that we went out and purposely selected as many people as we could who were dissatisfied, because we felt that the crux of something really important might lie with those people. So the representation of the levels of adequacy in our study are not necessarily representative of the population at large. But I think even though people's stories differed, what it came down to is, were their expectations met? And some people didn't even really register that they'd had expectations until after the fact, until often they weren't met. They hadn't gone into that as a formal part of their decision-making process. And then the ease or straightforwardness of having to deal with symptom resolution that did not go as planned. And I think this is where that whole concept of extra effort comes in, and where the stories tend to become very individual. People who had lots of disposable means, simply when they came to the end of their physiotherapy session, if they felt they hadn't had enough, went out and went privately and bought more physio. People who could not afford to do that were basically stuck at an intersection saying, I've used all the therapy that's provided for me. I don't have the results that I want. What can I do? And so I feel that these concepts have pointed to something that we now need to start to take apart and say, how much of this is about expectations, realistic or not, being met or not being met, and how much of it is the extent to which patients are individually supported through adapting to their knee. And I think that there's things that the system can do in response to that. And there are things, obviously, that are beyond the reach of the system. So, I tried to focus in on what the system could do. Did that somewhat answer your question?
Yeah, yes, I think so.
Okay.
Yes, thank you for that. And I think the important thing to recognize here is that the majority of people have some good outcomes. And so what you're looking at is that group that were classified as dissatisfied using that simple question. So that's helpful. Evelyn asks, am I too old at 81 for TKR? I'm reasonably active, getting single injections, but they are getting short-lived. Also, what is the infection rate after surgery? I'm not sure, Charlyn or Ellen, would you able to comment on that?
I will say quickly that I definitely cannot answer those questions, except to say, because as I said before, I'm not a physician, and but I think the opportunity to have the conversation with first, I guess, a family physician and then a surgeon to say, this is my physical health, this is my age, this is what I'm hoping that this surgery might do for me. Do you think it can do it? So it speaks to having that expectation conversation. Charlyn, do you have anything?
No, I don't have anything to add, and I can't tell you about the exact infection rate. And that may, in fact, depend on your any other conditions you have, any impact of the previous injections, etc. So I think Ellen has stressed in this presentation how important it is to consciously frame your expectations and to then very actively discuss those with your physician, with your family doctor first, and then a surgeon. And to feel very comfortable that you're getting clear answers to these specific concerns you have. So I think that, a fear of infection is one thing, and, what's behind that. You may want to really ask your physician about those specific things. And then what specific activities do you really want to be able to do should you have a knee replacement? So I think conversations, getting clear before you have the surgery rather than after, as with many of Ellen's interviewees, is really critical to that decision about should I even consider it. I'll leave it there.
Charlyn, can you tell me, in that study of 500 people throughout BC, were there people over 80?
Ellen, I believe there were.
Yes, there were. I can't tell you how many, but there were.
Okay, that's great. So age in itself is not necessarily a factor.
No.
Well, no, and if you think about historically, people used to be pushed as late as possible to have this surgery, which meant that you were often having it at least in your 70s, because the idea being that, this might save you from ever having to replace a replacement. So I would definitely say, as a layperson, I feel confident that being 81 is not a disqualifying age. I think it's more got to do with what you're hoping for and your physical condition and support system and so on.
Yeah.
And I'll just add, Ellen, as you were talking about that trend to do surgeries on younger and younger age groups, partly because that the replacements are lasting longer, but also people can retain. One of the big risks in aging is sarcopenia, losing muscle mass. And the less we use our joints because of pain or anything else, the more muscle we lose. So there is an important trade-off here to say, if you're considering getting a knee replacement, you really want to do it earlier so that you don't have the muscle wasting that leads to frailty, falls, etc., and that you can rehab adequately and actively to get those muscles around your knee back in shape to keep you moving effectively.
Yes, good advice. That's very helpful. We have a comment from Sally here. What I found interesting is that part of your cohort were chosen because they had previously said they were dissatisfied or very dissatisfied with their TKR, but you found there was a sample in this group who had optimal adequacy. Do you have any idea why they might have ticked dissatisfied? And I'm adding on that simple question on their survey.
Yes, and that comes down to me perhaps not being clear enough when I was describing it. So when we went out to recruit for this study, I tried to recruit as many people as I could who had ticked off dissatisfied and very dissatisfied. That did not mean that I didn't also include people who had ticked off very satisfied and satisfied. And those are the people. So you won't remember, but the satisfaction question had 5 levels: very dissatisfied, dissatisfied, neutral, satisfied and very satisfied. And we had people in the study in each of those 5 satisfaction categories. So I just sort of overloaded where I could on the people who were dissatisfied, because I hoped they might hold the secret answer to what we needed to do to make everybody satisfied with this.
Yeah. And if I can just add, Ellen's next, the next part of the thesis that she's working on will look at how those 2 measures align. How do people's responses in response to that question about satisfaction align with their descriptions of adequacy and adapting to a new need? So that's what she's working on right now.
Oh, we'll have to have her back for sure. And Tracy comments, this is so helpful to know what, in quotes, poor outcomes means when a sports doctor or physio refers to the potential negative results of surgery. So I think a comment on how helpful your findings are, Ellen, in understanding what negative outcomes might be.
Well, I'm glad that I hope that this has been helpful for everybody, whether you've had the surgery or not, or contemplating it. It really comes down, there's a lot that the healthcare system can do, but there's also, we as patients need to go in as our own best advocate and know as much as possible, not about the ins and outs of what the surgery involves necessarily, but what am I really hoping? Because I will say some of the more heartrending interviews where people were saying, you know, I thought I was going to be able to do X or Y, and I simply can't. And, you know, I think you noted that somebody said, or maybe it was you yourself, Joan, who said, I don't want people to lose sight of the fact that most of the people who have this surgery are happy with it and feel that it was the right thing to do. We're just trying to make everybody feel that way to the extent that that's within the realm of possibility.
Yeah. Well, I see we're almost out of time, and that's a great maybe ending on that very positive note, is that there's still room to really improve outcomes for everybody. And that's obviously our goal for healthcare, and I'm sure the motivation for most healthcare professionals as well. And so on behalf of everyone who joined us today, I want to thank both you, Ellen and Charlyn, for this great presentation and for talking to us about the results. It was very, very helpful. And I think it gives us all something to go away with. And even if our friends and neighbors are considering it, we can give them some good advice. Make sure you talk to your healthcare provider about everything you're expecting and get all your questions answered in advance. So very, very helpful. So thank you to everyone who joined us today as well. And there's still a few more events before the end of March. And so I hope we will have an opportunity to see you at some of those last events. And if you're not sure what's coming up, you can visit our website, OkanaganEmbraceAging.com, for information about the rest of the events till the end of the month. And so thanks again to everyone, and have a lovely afternoon. Bye for now.
Bye.
Bye.
Thank you.